Morning, everyone, and welcome to the eighth session of the Nomics series. The series is designed to empower clinicians and healthcare providers, and for anyone interested in learning more about how genomics is being utilized across various clinical and healthcare settings. I'm Atidara, your host for this webinar, working at Karkinos Healthcare Private Limited as a bioinformatician. Today, we have with us Dr. Vishala Rosemary Varghese, who is dedicated consultant radiation oncologist at the Christian Institute of Health Sciences and Research in Dimapur, Nagaland. And today she will be speaking on selection of germline panels in cancer, ASCO guidelines simplified. Before we all listen to her insightful presentation, I would like to take this opportunity to introduce her. After completing her MBBS, Dr. Varghese pursued an MD in radiation oncology from the prestigious uh, Christian Medical College Fellow, graduating in 2021. Driven by a commitment to addressing the high incidence of cancer in the Northeast, Dr. Varghese moved to Dimapur, where she now provides comprehensive clinical oncology services. Her expertise and passionate care is invaluable to the community she serves, making a significant impact in the lives of people. Please join me in welcoming Dr. Varghese. The stage is now yours, Doctor.
Thank you so much for this opportunity. I'll be talking on selection of germline genetic testing panels in patients with cancer, the recent one which ASCO had released this year. And just a disclaimer, I'm not an expert in cancer genetics. I'm still learning. I don't have such an in-depth knowledge about it, but whatever I do understand, I'll try to impart today. And of course, if I'm not able to answer any queries, of course, I'll need help from the genetic experts here on the panel. So, yes, so basically, this addresses four clinical questions, and those are: what is the importance of family history collection in the setting of germline multi-gene panel testing, and what elements of family history are important? When and how should multi-gene panel germline testing be used when genetic testing is indicated? Which genes are generally recommended for germline genetic testing for patients with selected cancers? And which patients should be offered germline genetic testings who will have or have had somatic germline genetic tumor testing? So, just an introduction, genetic testing basically is recommended for patients with cancer to identify inherited risk like BRCA testing for ovarian, breast cancer, pancreatic cancer, and prostate cancer. And it can reveal future cancer risk for patients and maybe potentially their relatives. And it can also affect the use of targeted cancer therapy. So the first question that we need to address is, of course, the importance of family history collection in the setting of germline testing and what elements are most important. Now, if you ask why is family history important, it is central to the value of the germline testing because appropriate germline genetic testing depends on on an accurate family history of cancer. And of course, it also helps in proper interpretation of genetic test results, assessment of future cancer risk. It's integral to provide a risk assessment to the patient and the family, and of course, to inform screening and prevention recommendations for individuals with pathogenic variants. So now this, as I said, this is the gold standard of family history, a pedigree chart. And this is mentioned in one of the paper by ASCO expert guidelines on how to collection and use of family history for oncology providers. But as we all know, of course, in a busy OPD setting, this is not feasible. And unless you have a genetic counselor or someone with a genetic background to help you in taking this detailed history, because it's quite time consuming, and and sometimes the patient won't know so much about their families, like maybe first degree relatives, second degree relatives, only not third degree, and they may not be aware of some. So maybe if they're not in touch with some members because they move far away, they may not be aware of what's happening with them, and sometimes parents may not tell them if they're adopted or if they were conceived through IVF. So all those factors are also there. So the recommendation is at least minimum in a family history minimum. If you have to take a family history to ask, at least ask about the first degree relatives. Those include siblings, parents, and children, and second degree relatives like grandparents, aunts, uncles, grandchildren, nieces, nephews, half siblings. So both you have to go for both the maternal and the paternal side also, and the ethnicity. And for each cancer case, the family, you have to establish what is the age of the cancer diagnosis, what is the primary type of cancer, and if any results for any cancer predisposing testing was done for any relative. And also, if possible and if time permits, also family history should be taken, at diagnosis and updated periodically. And gender also of the biological relatives is important. And if time permits, if there is time, then maybe more to third degree relatives like cousins, if there is any consanguineous marriage, and any personal family history of colon polyps. uh, Major like hereditary cancer predisposed syndromes, mostly they'll be autosomal dominant, they'll have high penitence, and family history of cancer close relatives is most relevant. So whenever a family history is taken, the red flags should point out that maybe this person is having cancer predisposition syndrome should be if there's an early age of onset of cancer, if there's multiple relatives with cancer on the same side of the family, and multiple primary tumors, especially in the same organ in a single individual. And some barriers are, of course, that happens when we do a family histories, of course, that there is limitations to patients' knowledge of their family history. Sometimes it can be inaccurate and incomplete. And the data shows that paternal lineage seems less complete, maybe because sometimes they say maybe men are less aware of their side of the family. If there is a small family, it's more difficult to assess the presence or absence of a heritable condition. And some patients may choose not to explore family history because of fear, or maybe they're not aware of how important a family history is to their care, and not understanding also that important elements of a complete family history, or what type of cancer information they should report. So these are all barriers when we take a history, that barriers that the patient may present with. So next question is, when and how should a germline testing panel be done? So a germline multi-gene panel testing will include genes in which pathogenic or likely pathogenic variants can confer a high relative risk of cancer. For example, BRCA1 or 2, or MLH1, MSH2, MSH6, PMS2, EpCAM, and genes with a more moderately increased risk of cancer like ATM or CHEK2. So, what are the benefit if you order a multi-gene panel testing? So, one thing is, of course, every patient may not be aware of their family history. For us to specifically choose, okay, these genes should be tested, these genes should be not. So, in that case, maybe doing a multi-gene panel testing could benefit. And there can be unexpected pathogenic variants in clinically significant high or moderate penetrance genes, which can be identified by broader panels, which includes genes beyond which would be indicated by the patient's personal and family history. So there are some, of course, but there are benefits and there are also harms if you order multi-gene panel testing. One, of course, is, of course, a patient will be more anxious because, and especially if the finding is without any clear clinical significance. And sometimes, especially if we don't have any person with a genetics background in our hospital or in the department, some results can be misinterpreted. Like example, variant of unknown significance (VUS) and findings in genes with uncertain clinical validity. Sometimes unnecessary surveillance may be done, and leading to risk reduction surgeries and all that, which may not be indicated. Sometimes risk to the patient may be overestimated if the history is not representative, and increased possibility of identifying variants that represent clonal hematopoiesis than germline variants. So these are the lists that they've given of for each cancer type, and the more strongly recommended, the less strongly. But then I'll come into detail subsequently. We'll move on to the next question: which genes are generally recommended for testing and for which patients? So they've divided into strongly recommended genes and strongly recommended genes. So these genes are the ones which have a high relative risk, that is more than four-fold increased risk for that specific cancer, or genes with a lower relative risk that are highly actionable. Example, recommended for prophylactic surgery. So these genes should be tested in all patients with that cancer or with a family history of that cancer. The other one is less strongly recommended genes, which have a moderate relative risk, maybe less than 4 times increased risk for that cancer, or less actionable. So for breast cancer, more strongly recommended panel that genes that they recommend for testing would be BRCA1 and 2, PALB2, CDH1, P10, SKT11, TP53. Less strongly recommended would be ATM, BARD1, CHEK2, RAD51C, RAD51D, and NF1. For colorectal cancer, it's APC, EpCAM, MLH1, MSH2, MSH6, MUTYH, NLT, NTLH1, PMS2, POLD1, POL, BM, BMPRA1, SMAD4, STK11, TP53. And endometrial cancer, the strongly recommended ones are EPCAM, MSI, P10, STK11. Gastric cancer, it is APC, CTNNA1, EPCAM, MSI, BMPR1A, CDH1, SMAD4, STK11. For GIST, it will be KIT and PDGF array. And if it's succinate dehydrogenase deficient or mutant tumor, then you have to do SDHA, SDHAF2, SDHB, SDHC, SDHD. If it is NF1 mutant tumor, then we have to do an NF1. Medullary thyroid cancer, as we all know, it's of course a red gene. And if it's a non-small cell cancer, if it is EGFR tumor positive with pathogenic variant like T790M is found with no previous EGFR therapy, then definitely EGFR and STK1 should be tested. For adenocortical tumors, APC, EPCAM, MEN1, MSI, and TP53. For cutaneous melanoma, CDK N2A, CDK4. For uveal melanoma, it's BAP1. These are the strongly recommended. These strongly ones are on the right side. First column is for the strongly recommended. So epithelial ovarian cancer, BRCA1 and 2, BRIP1, EPCAM, MSI, PAL-B2, PMS2, RAD51C and D. For pancreatic adenocarcinoma, it will be ATM1, BRCA1 and 2, CDK4, CDKN2A, EPCAM, MSI, MSI, PAL-B2, STK11 and TP53. For pheochromocytomas and paragangliomas, if it's FH, MAX, RET, SDHA, A and B, C, D, TME, M127, NF1 and VHL. And for prostate cancer, BRCA1 and 2, EPCAM, MSI, and HOX P13. For renal cell cancer, it is BAP1, FH, FLC, and MET, SDHA, SDHAF2, SDHB, BCD, P10, and VHL. And for sarcoma, it is TP53. So there were some footnotes in this. So they've said that patients with clinical neurofibromatosis have a significant increased risk of breast cancer before the age of 50 years. So if if there is no clinical neurofibromatosis, the risk of breast cancer for these patients who are heterozygous for an NF1 pathogenic G variant is less clear. And TP53 pathogenic variants are rare in patients with breast cancer diagnosed over 45 years, unless there is also a personal family history of a leaf from any associated cancer, like breast cancer less than 46 years, or soft tissue sarcoma, osteosarcoma, CNS tumor, adenocortical carcinoma. And testing for TP53 in older patients without suspicious family history needs to balance the risk of identifying TP53 as a variant of chip that is not inherited. Now, the fourth question is, which patients should you offer germline genetic testing who will have or have had somatic genetic tumor testing? So this one, they looked at a paper by ESMO, which was the germline focused analysis of tumor dendritic variants in 49,264 patients, which is, of course, they did registry from MSK impact study. So based on this, they divided genes into 3 actionable classes: most actionable, highly actionable, and standard actionable. So there were total 40 genes, and most actionable had almost 7 genes. The other 2 were high and standard had 33 genes. So based on these recommendations, ASCO has recommended that all these genes, the BRCA1, 2, BRIP1, MSI, PALB2, RAD51C and D, RET, SDHAF2, SDHB, CD, and TME M127, TSC2, and VHL. All patients with tumor pathogenic variants in these genes should be offered germline testing. But if the patient is less than 30 years, you test you test APC, P10, RB1, and TP50 only if the patient is less than 30 years. And the next one is any patient with tumor pathogenic variants in these genes may also be offered germline testing, which is ATM, BAP1, BRD1, CHEK2, DICER1, FH, FLCN, NF1, pole D1, pole, and SDHA. And if and testing is done for patients less than 30 years only for SDKN2A and SMARC-CA 4. If like in case the oncologist prefers a conservative approach, then they have advised for these testing to be done. Like in case maybe they feel maybe it's a resource limited setting, or the patient cannot afford to pay so much, because genetic testing also of course is expensive. In that case, these tests, they can be for the specific cancer. They advise these genes be tested. So ATM gene for breast cancer, gastric cancer, epithelial ovarian cancer, pancreatic adenocarcinoma, or prostate cancer. BP1 for melanoma, renal cell cancer, malignant mesothelioma. BARD1 for breast cancer, CDKN2A for melanoma, pancreatic adenocarcinoma, CHEK2 for breast cancer, colon cancer, prostate cancer, thyroid cancer, DICER1 for pleuropulmonary blastoma, cystic nephroma, embryonal RMS, ovarian sertoli lytic cell tumors, ovarian sarcoma, neuroblastoma, and thyroid cancer. FH for paragangliomas, pheochromocytomas or RCC. FLCN for RCC, NF1 for breast cancer, GIST, paraganglioma, pheochromocytoma, POL1 for colorectal cancer, and POL also mutation for colorectal cancer, STHA for GIST, PPGL, and RCC, and SMARC-CA for malignant rhabdoid tumors, and SGC OCT. So just sharing experience from my institute. Basically, it's a 200-bed secondary care hospital in Dimapur, Nagaland, and basically it's was made after tripartite agreement with the government of Nagaland, CMC Vellore, and Emmanuel Hospital Association. So currently in our institute we have four radiation oncologists, including me, one surgical oncologist, and one GI oncosurgeon, and we have a dedicated weekly MDT. So at present, we don't have a medical oncologist with a DM degree in the state. We have only one with a fellowship who is in the capital city, Kohima. And I'm not aware of any oncopathologists in the state. And we have no genetic facilities also available here. So some of the challenges that we face with genetic testing is, of course, financial issues. And considering that we are a mission hospital, 99.9% of our patients are government scheme holders. And if it's not covered under the government scheme, then they find difficulty to pay. And even if they are affordable for testing, of course, they may not be affordable for the targeted therapy, which is indicated for that testing. And we don't have any lab in the state that does genetic testing. So for all of this, our samples have to be sent outside, and mostly we send to Carkinos at our molecular testing. And also, even if we get a report, we don't have any experience in genetics here to counsel us. Like if a VUS comes, how significant is it? How should we wait after 6 months, see if it becomes significant or not? So those there's nobody there to help us or guide us in that area. There's not even a medical oncologist, so we are not sure how to proceed. And we have to give the chemos ourselves. So it's a difficult decision for a radiation oncologist to make. That said, there are some common genetic tests that we do, like we do MSI here because we have a lot of colorectal and stomach patients, and BRCA testing also because breast and ovary, serous ovarian cancers we see. And yeah, sometimes for endometrial cancers also as recommended, like pole mutation, MSI also we have to. So just summarizing just what I've said, this is basically the ASCO guidelines. Patients should have their family history and ethnicity recorded, and we should offer multi-gene panel testing when multiple genes are relevant. The minimal testing should include the most strongly recommended genes, and a broader panel may be ordered based on its benefit and potential harm. And patients meeting the criteria should be offered general testing regardless of the tumor testing. And patients with a pathogenic or likely pathogenic variant of tumor testing should be offered germline testing. And just sharing the genes that are recommended for each site by Kakidos, which they've shared once on their site. So thank you so much. And yeah, if there's any queries, you can always contact me through this. Yeah.
Thank you, Dr. Varghese, for this insightful presentation. I would now like attendees to keep posting their questions in chat. And meanwhile, I have a small question to ask. When you mentioned about the risk of genetic testing, you mentioned that that test could have the risk of identifying clonal hematopoiesis as well. Can you comment on that?
I think most likely that maybe I'm not really sure. Maybe I need some help from Dr. Vinod also. Even probably what I mean to say, maybe it's not genetically relevant. Maybe it has some other relevance, which is not maybe relevant to the testing in question genetic. That's what I feel, but I'm not very sure. Dr. Vinod, would you just would you help me out with that?
Yeah, thank you. So, clonal hematopoiesis is something that we need to always keep in the mind when we come across a variant, especially in a certain subset of genes, which might masquerade as a germline variant. But in theory, these are somatic variants, and these are age-related changes or mitosis-related changes, largely in the stem cells of the blood, and they may not be really representative of the germline. Uh, just to keep in mind that it is an artifact, and of course, it comes with additional risk for some cancers or developing some cancers, especially hematological malignancies. Um, but when you come across certain genes and certain set of mutations, always you need to have it in the back of your mind that it might not be germline. Thank you.
Okay. Okay, sir. Thank you, sir.
Thank you, sir. If people have questions, they can start putting them in chat. Yes, Harish, please.
Rather than pointing it out as a question, one of the key factors that I would like to share with many people as such here today is that people think as such genetic testing is exorbitantly expensive. It is expensive, but the fact that what most people don't realize is that genetic testing costs just as much as a single organ MRI. It comes somewhere around 15 to 20K. That's the range of genetic testing basis tests that are really relevant and has extreme value as per ASCO guidelines. And the other aspect as such is that okay, what will you do with what are the most expensive ones? Trust me, it's not more than a whole body MRI. That's how it is designed as such, and this awareness should be spread across to a lot of people. So we just wanted to share that. Share that. Thank you.
Thank you, Harish. Anything you would like to comment on, Dr. Varghese, before we end up this session as a take-home message?
Not really, but I feel that genetics is an evolving field. There's so much that we don't know, and it's quite in depth. So I think maybe in a few years, recently, ASCO changed their guidelines. I mean, for breast cancer, initially it was if it's a young lady less than 40 with TNBC or a family history, then you test for BRCA and all. Now it's like anybody less than 60 needs to be tested. That's the new guidelines which came out. So I think it'll change. Maybe it'll be a game changer in the coming years and days ahead. Maybe we'll have more genetic testing popping up, and I don't know. Hopefully, with maybe if we, I don't know if we test more, I hope the price will also come down. And yeah, that's what I feel. It's coming up in a big way in the oncology at least. And there's so much to know, and this is too vast.
Interesting. So, what are the main cancers which are more prevalent in Northeast compared to other parts of India? And do you think they have gained enough attention when it comes to testing across different parts of India?
Okay, the most common cancer in this state is nasopharyngeal cancer. I think it's quite rare in the other parts of India. So this is the number one state with nasopharyngeal cancer. And I see a lot of colon cancer patients also, very young, because I remember in my 3 years of residency in Vellore, I saw just one girl who was 24 years with colon cancer. But here there are so many young people in their 20s and 30s with colon cancer, esophageal cancer, stomach cancer, and who have a family history significantly. And I think I don't know, there's not so much attention also that this, I mean, they've been getting. I'm not sure if it's because of the diet, because their diet is heavy on red meat. So red meat also has been implicated like in the causation of colorectal cancer. I'm not sure if that is the reason. Diet or environment, I'm not, maybe multiple factors be there. So I think it's not getting as much attention as it should. Maybe that's what I feel.
Okay. I think there are no questions, and I think we can wrap up this session. Thank you, Dr. Varghese, for this presentation. And our next session is going to be on 24th of August. I hope to see you all there. Thank you.